Hello friends, today I will talk about approach to patient with hyponatremia. Here in this video, we will talk about the fluid and electrolyte balance, the presentation of the hyponatremic patient, how to diagnose the patient of hyponatremia and its management part. First is the disclaimer. This video is made for educational purpose only and there is no endorsement for any brand or company. Let us discuss about the total body water. As we know that human body, it has 60% of the water and 40% is the solid. And out of this 60% total body water, extracellular fluid is 1/3 and intracellular fluid is 2/3. Intracellular fluid means the fluid which is within the cells, and extracellular fluid is the fluid which is outside the cell. Extracellular fluid is further subdivided into two, that is interstitial fluid and the intravascular fluid. Intravascular means the fluid which is present within the plasma cells, and the interstitial fluid is the fluid which is present in between the cells. So if we see a man with 100 kg of the weight, he has 60% of the body water. 60% of the body water is present in the men and 50% of the body water is present in women. So in this 100 kg man, if he has 60 liter of water, then 2/3 is the intracellular fluid, that is 40 liter is the intracellular fluid, and the extracellular fluid is only 1/3, that is 20 liter, out of which 3/4 is the interstitial fluid, that is 15 liter, and 5 liter or 1/4 is the fluid which is present in the vascular compartment, that is plasma. Let's discuss about the basic physiology of the fluid and electrolyte. As we know that kidneys play important role in the regulation of the sodium and the water in the body. Whenever there is water deficit in the body, the patient feels dehydrated, there is fall in blood pressure, or uh, there may be increased solute concentration, or we can say increased osmolality, and the signal of the dehydration or water deficit is regulated by the thirst center, and whenever the thirst center is stimulated, there is occur increased excretion of the or increased secretion of the ADH. So whenever there is a fluid deficit, there is increased osmolality due to increased serum sodium, or we can say decreased circulating blood volume. This stimulates the hypothalamus for ADH release. ADH is also called ABP, that is vasopressin. It is secreted by the hypothalamus, and this ADH acts on the distal tubules and collecting ducts of the kidney and increases the water permeability. Means it increases the reabsorption of the water. So approximately 18 liters of the water is reabsorbed under the influence of the ADH. So whenever there is a water deficit, or there is dehydration or fall in blood pressure or increased osmolality, the body thirst center gets stimulated and there is increased secretion of the ADH, and ADH causes a reabsorption of the sodium in the distal tubules and the collecting ducts, and there is increased reabsorption of the water. What happens when there is water excess? Exactly opposite happens. Whenever there is excess of the water, or patient in overloaded state or hypervolemic state, there occurs decreased secretion of the ADH, and this decreased secretion of the ADH prevents the reabsorption of the water by the collecting ducts, and hence there will be increased urine output. And due to water excess, there is volume expansion, and this volume expansion leads to increased secretion of the ANP, that is atrionatriuretic peptide, due to atrial stretching, and this promotes the diuresis and natriuresis. So increased due to water excess or volume expansion, there is decreased ADH secretion, increased ANP, which will further cause decreased water reabsorption and increased urinary output. Therefore, it helps in maintaining the water balance in the body. Coming to the sodium regulation, as we know that sodium is the major extracellular fluid cation. It constitutes about 140 milliequivalent per liter extra cell it is about 140 milliequivalent per liter in extracellular fluid and 25 milliequivalent per liter in the intracellular fluid. About 85 to 90% of the sodium is extracellular, and it is responsible for the more than 90% of the total osmolarity in the extracellular fluid. Major function of the sodium is to maintain the extracellular fluid volume, and hence it helps in maintaining the blood pressure. Daily requirement of the sodium is about 100 milliequivalent, or we can say 6 gram of the sodium chloride. Whenever there is excess of the sodium, it is chiefly excreted by the kidney, and some amount of the sodium is also excreted in the sweat, but the quantity is about 30 to 65 milliequivalent per liter. The major extracellular fluid cations are sodium, chloride and bicarbonate, and but potassium, organic phosphate esters like ATP, creatine phosphate, phospholipids, they are predominantly found in intracellular fluid. These solutes which are present in the extracellular fluid or intracellular fluid, they determine the tonicity or we can say osmolarity of that compartment. But there are certain solutes, for example urea, they don't have any role in the increasing or decreasing the osmolality of the that compartment. So these are urea is called ineffective osmol. Coming to the sodium, whenever there is sodium deficit in the body, the deficiency of sodium leads to hypovolemia, and this in turn activates the angiotensin renin angiotensin aldosterone system. The angiotensin 2 helps or causes or increases the sodium reabsorption at the proximal tubules, and aldosterone increases the reabsorption of the sodium in the collecting ducts. The absorption of the sodium from the collecting duct under the influence of aldosterone is very perfect, and there occurs no urinary sodium loss. But this reabsorption of the sodium in the collecting duct occur at the loss of potassium and at times hydrogen ion in the urine. It means that whenever in the sodium deficit state, the aldosterone causes reabsorption of the sodium in the distal tubules in exchange for the potassium and the hydrogen ion. And also uh, in cases of diarrhea, where the body's priority is to reclaim sodium more than potassium or more than hydrogen ion, again there is loss of electrolytes in the diarrhea stool. So potassium is lost there, so the patient can have hypokalemia in such situations. Secondly, whenever there is sodium excess, whenever there is sodium excess, there is this leads to increased extracellular fluid volume. So the secretion of angiotensin 2 or aldosterone will decrease, but volume expansion or increased extracellular fluid causes stretching of the atrias, and that causes increase in secretion of the atrial natriuretic peptide. The decreased secretion of the angiotensin 2 and aldosterone, sorry, spelling is written wrong, aldosterone, aldosterone, aldosterone. The decreased secretion of angiotensin 2 and aldosterone will cause or will lead to decreased renal absorption of the sodium, and because of over volume or increased extracellular fluid, the stretching of the atrias will lead to increased ANP. This ANP will lead to natriuresis and diuresis, and hence whenever there is sodium excess, there will be decreased angiotensin 2 and aldosterone and increased ANP, and this will lead to decreased renal absorption of the sodium and increased water loss, or we can say diuresis. And also natriuresis. Once again I will repeat, whenever there is sodium excess, there will be decreased secretion of angiotensin 2 and aldosterone, and there will be no reabsorption of the sodium in the distal tubules or the proximal convoluted tubule, so more and more sodium will be lost in the urine. Secondly, whenever there is sodium excess in the body, it leads to increased extracellular fluid volume, or we can say volume expansion states. There is increased secretion of the atrial natriuretic peptide. This atrial natriuretic peptides leads to natriuresis, that is loss of sodium, and diuresis, that is loss of water in the urine. In this way, the kidneys, they play important role in maintaining the balance of the sodium and the water. Coming to the hyponatremia, as we know that normal quantity of the sodium in the extracellular fluid is 135 to 145 milliequivalent per liter. Whenever the plasma sodium is less than 135 milliequivalent per liter, we call it as hyponatremia. The incidence of hyponatremia is approximately 2% in hospitalized patient, and it is rarely seen in the ambulatory patient. If it is present in the ambulatory patient, it reflects the chronic disease status. Acute and severe hyponatremia has a very high morbidity and mortality, and even the rapid correction of the hyponatremia can lead to neurological deficit and even death. I will discuss this in the next subsequent slides. So, low sodium in the extracellular fluid leads to decreased serum osmolarity, so leading to true hyponatremia, which is characterized by the hypoosmolarity. Hypoosmolarity or decreased osmolarity varies in hyponatremic patient depending upon the etiology. So the etiology of the hyponatremia is classified on the basis of two criteria: osmolarity and the extracellular fluid volume. Whenever a patient presents with hyponatremia, we must rule out whether it is a true hyponatremia or pseudohyponatremia. Pseudohyponatremia means the patient's osmolality will be normal or high, and true hyponatremia means the plasma will have low osmolality. So it is important to differentiate between true hyponatremia and the pseudo hyponatremia. And further, the true hyponatremia is divided into three parts depending upon the extracellular fluid volume status of the patient, and this is hypervolemic, euvolemic, and hypovolemic hyponatremia. So whenever a patient of hyponatremia comes to us, we have to first uh, decide whether it is a true hyponatremia or the pseudo hyponatremia. True hyponatremia will always have a low osmolality. Pseudo hyponatremia will have a normal or high osmolality. Once the true hyponatremia is established, we will see the fluid status of the patient, and depending upon fluid status, we will further categorize it into hypervolemic, euvolemic, and hypovolemic hyponatremia. So, the true hyponatremia is characterized by the hypoosmolality, or we can say the patients have a low plasma osmolality. The plasma osmolarity is usually less than 275 milliosmol per liter in true hyponatremia, and these patients may be dehydrated or their hydration may be fair. And pseudo hyponatremia is characterized by normal or increased osmolarity. Normal osmolarity is seen in the patients with hyperlipidemia or hyperproteinemia, and high osmolarity is seen in patients with hyperglycemia or patients who are on mannitol or maltose. Just remember one thing, all the patients who have hyperglycemia, the plasma sodium concentration falls by 1.6 to 2.4 millimole per liter for every 100 milligram per deciliter rise in plasma glucose concentration. In pseudo hyponatremia, the hydration status of the patient will be normal, and in true hyponatremia, patient may be dehydrated or his hydration may be normal. So when we are discussing about the hyponatremia, it means we are discussing about the true hyponatremia, in which the patient has a low osmolality because of low sodium. So coming to the true hyponatremia, that is hypoosmolar hyponatremia, as we discussed in initial slides, that we divide these patients into three categories depending upon the volume status of the patient. So the first is the hyponatremia with extracellular fluid volume depletion, means the patient's volume status is depleted in this condition, or we can say hyponatremia with low fluid volume status, or hypovolemic hyponatremia. These patients will be dehydrated, and there will be the here in these patients a reduction in the total body sodium is quite more as compared to the reduction in the total body water. Though these patients are dehydrated, but the reduction of the sodium will be more as compared to the reduction of the total body water. Once we have confirmed it as a true hyponatremia, we will see the volume status. If it is patient is dehydrated, we will see the urinary sodium. If the urinary sodium is less than 15 milliequivalent per liter, it means the kidneys, they are working properly. Urine sodium loss is very less, so the patient has a extra renal cause of true hyponatremia. And these patients, if we get proper history, these patients will have the history of vomiting, diarrhea, or peritonitis. And if the urinary sodium is more than 20 milliequivalent per liter, it means their kidneys are not working properly. The sodium reabsorption is not proper, and the cause here for the hyponatremia will be a renal cause. And these patients may be on excessive diuretics. They may be having salt losing nephropathy, or they may be patient of diabetic ketoacidosis or cerebral salt wasting syndrome. Secondly, hyponatremia with hypervolemia. Hyponatremia with hypervolemia means these patients, in these patients there will be increased extracellular fluid volume, and these patients will be edematous. So this hyponatremia is called hypervolemic hyponatremia. Patient is edematous. There will be increase in total body water. The total body water increase will be very much as compared to the total body sodium. So again we will see the urine sodium values. If the urine sodium values are less than 20 milliequivalent per liter in hypervolemic state patient, it means the kidneys are functioning properly, and they, they these patients may be suffering from the congestive heart failure, cirrhosis, or nephrotic syndrome. And if the urinary sodium concentration is more than 20 milliequivalent per liter, it means they are having renal problem, and they may be suffering from the renal failure, or the cause for hyponatremia in these patients may be renal failure. If the patients have a hyponatremia with normal extracellular fluid volume, we call it as a euvolemic hyponatremia. The patients are normovolemic, means there is, if we see comparatively, there will be increased total body water as compared to the body sodium. And this hyponatremia with euvolemic hyponatremia is usually seen in patient with syndrome of inappropriate ADH secretion, post-operative pain, hypothyroidism, glucocorticoid deficiency, psychogenic polydipsia, or drug-induced. How do we check the hydration status of the patient? We will see his tongue, axilla, and we will elicit the history of any diarrhea, vomiting. We will see his skin. We will these patients will give history of diuretic use, and the hypervolemic patient will have signs of edema, clefts, or clefts in the lungs, or ascites. This is the basic approach of a hypotonic or true hyponatremia. Uh, we will see the volume status of the patient, whether he is a hypovolemic, euvolemic, or hypervolemic. Then we will check their urinary sodium values, and this I have discussed my previous slide. The patients of hyponatremia are further divided on the basis of their onset and severity. The if the sorry hyponatremia develops in less than 48 hours, we call it as a acute hyponatremia. And if this hyponatremia develops over a period of 48 hours or more, we call it as a chronic hyponatremia. Similarly, mild hyponatremia is when sodium value is less than, or we can say it is between 130 to 135 milliequivalent per liter. Moderate hyponatremia, we call it, is when the volume lies between 125 to 130 milliequivalent per liter. And severe hyponatremia, when the volume sodium value lies less than 125 milliequivalent per liter. How does the sodium loss or hyponatremia affects the body, or how the symptoms occurs in the patients with hyponatremia? So the sign and symptoms in hyponatremia, these are basically not due to reduction in the sodium levels in the extracellular fluid, but it is because of the increased increase in volume of the extracellular sorry increase in the volume of the intracellular fluid, which leads to swelling of the cells in the brain, and further this cellular swelling leads to sign and symptom. What happens in hyponatremia? We can see that just a minute. In hyponatremia, the patients have a hypoosmolality of the extracellular fluid. This it means low concentration of the solute. So the water moves from the lower concentration to the higher concentration. Means so the water moves from the in, moves from the extracellular fluid into the cells. That is the intracellular fluid. This is the brain cells, it goes into the intracellular fluid or within the cell, and there occur cellular swelling, or we can say the patient develops a cerebral edema. In tissues such as skeletal muscle, the disease is of little consequences, but this intracellular shift of the fluid causes more damage in the brain. When the cells of the brain they swell, this increases the intracranial pressure, and since the brain is enclosed within a fixed skull, this increased intracranial pressure decreases the cerebral blood flow, and it leads to hypoxic brain damage. As the skill as the skull sorry skill as the skull is fixed closed space, such increased brain cell volume and resultant significant rise in intracranial pressure leads to the herniation of the brain. And this herniation of the brain is characterized by unequal or fixed dilated pupils, hypoventilation, cardiovascular instability, urinary and fecal incontinence, and at times respiratory arrest. So the symptoms of the hyponatremia, they can be categorized into mild milder symptoms with mild hyponatremia, symptoms in moderate hyponatremia, symptoms with severe hyponatremia. So the patients with mild hyponatremia, they will present with anorexia, headache, nausea, vomiting, lethargy. Patients with moderate hyponatremia, they will have a personality change, they will have abnormal behavior, they will have muscle cramps, muscle weakness, they have ataxic gaits, and those patients in whom the serum sodium level falls below 125, or the patient with severe hyponatremia, they will be brought in a drowsy state, they will have diminished reflexes, they may present with convulsion, coma, and even death. So the causes of the acute uh, hyponatremia are usually iatrogenic, means post-operative, premenopausal women, the patients who are given hypotonic fluids, they this hypotonic fluid will cause with increased secretion of the vasopressin. Patients of TURP or uterine surgery who are given glycine irrigation, colonoscopic preparations. These are the iatrogenic causes which leads to acute hyponatremia. The patients who are started on thiazides, patients who have psychogenic polydipsia, means they excessively drink water, patient who takes MDMA, or we call it as ecstasy, and in patient exercise induced, there are multiple causes which leads to uh, acute hyponatremia. So coming to the diagnostic approach, history and examination, they are helpful in identifying the hypovolemic hyponatremia. For example, patient will have a history of diarrhea, vomiting, burns, diuretics use. The degree of hyponatremia often correlates with the severity of the underlying condition, and it is an important prognostic factor. Three important diagnostic tests which are done for diagnosing hyponatremia is the plasma osmolality, urine osmolality, and urine sodium concentration. Plasma osmolality is calculated as 2 multiplied by sodium plus glucose in milligram per deciliter divided by 18 plus BU1, that is milligram per deciliter divided by 2.8. Normal plasma osmolality is 275 to 290 milliosmol per kg. So the hyponatremia which we are discussing is a true hyponatremia. It is associated with low plasma osmolality, but if the osmolality is normal or high, it is not true hyponatremia, it is a pseudo hyponatremia. If hyponatremia occurs in the edematous patient, We have to rule out congestive heart failure, cirrhosis of the liver, nephrotic syndrome, and other renal diseases. And in hypovolemic patient, rule out renal losses, extra renal losses. I have discussed all these things in my previous slide. So the approach will be, first, if the patient comes with a low sodium or sodium less than 135 milliequivalent, just check the plasma osmolality. If it is more, that is more than 290 milliosmol per liter, then it is a true, or sorry, it is a pseudo hyponatremia, maybe because of hyperglycemia or mannitol. And if the plasma osmolality is normal, that is 275 to 290 milliosmol, then again it is a pseudo hyponatremia, maybe because of hyperproteinemia, hyperlipidemia, or it is a post URP case. And if it is less than 275 milliosmol, then it is hypoosmolar hyponatremia. It is a true hyponatremia. We have to check the urine osmolality. If the urine osmolality is less than 100 milliosmol per liter, it means he is passing very dilute urine. The patient may be having primary polydipsia or beer potomania, means excessive beer intake, or he is a case of post URP. So this is again not a thing which is to be bothered much. So when the patient has a plasma osmolality of less than 275, means true hyponatremia, and you think you have his urine osmolality more than 100 milliosmol, then you have to see the extra cellular fluid volume or hydration status of the patient. If the hydration status of the patient is the patient is edematous or he is hypervolemic, you check his sodium concentration. If the urine concentration are less than or more than 120, more than 20 milliequivalent, means he is excreting more sodium in the urine. His kidneys are not working properly, so it is a case of renal insufficiency or renal failure. If he is excreting less than 20 milliequivalent per liter of urinary sodium in the urine, then this is a case of heart failure, cirrhosis, or nephrotic syndrome. Similarly, the patients who are euvolemic, again we will check his urinary sodium. It is more than 2 milliequivalent, 20 milliequivalent per liter. It means his kidneys are, if euvolemic, means he has low osmolality, urine sodium is lost excessively in the urine. So we have to rule out cortisol deficiency, or we can say adrenal insufficiency, hypothyroidism, SIADH, other causes of ADH action. And if the patient is hypovolemic, again check the urinary sodium. If it is less than 20 or less than 10, this is a case of extra renal causes like vomiting, diarrhea, patient on diuretics, extra renal losses. If the urinary sodium is more than 20 milliequivalent per liter, it is a salt wasting nephropathies. We have to rule out recent diuretic use. Patient may be a case of hypoaldosteronism. Patient may be on bicarbonates, leading to excessive excretion of the bicarbonates, or patient can have a diabetic ketoacidosis. Or in other way, this was an algorithm, or we can also approach the case of hyponatremia in this way. Just first confirm the diagnosis of hyponatremia, rule out whether it is a pseudo hyponatremia. Pseudo hyponatremia patient will have a normal or high osmolality. Okay, once the we confirm the osmolality as a low osmolality, or patient has a hypoosmolality, is a true hyponatremia, you have to assess his renal status. If there is impaired renal function, means RFTs are deranged, it is a primary renal cause. If the RFTs are normal, then you have to assess the volume status of the patient. If the patient has features of edema, then the cause of hyponatremia may be congestive heart failure, cirrhosis, or nephrotic syndrome. And if there is volume depletion, then check the urinary sodium excretion. If urinary sodium is less than 15 milliequivalent per liter, then these it means patient might be having history of diarrhea, vomiting, burns, and pancreatitis. If urinary sodium excretion is more than 20 milliequivalent per liter, the patient may be on diuretic, start losing nephropathy. So once you check the volume status of the patient you ruled out hypervolemic status, you ruled out hypovolemic status. If the patient is normovolemic, assess his adrenal function, thyroid function. The patient may have adrenal and thyroid insufficiency, and if these two things are ruled out and there is no adrenal insufficiency or thyroid function are normal, then patient is able to dilute urine in response to water load. We do the water load test. If he is able to dilute the urine, then it is a psychogenic polydipsia. And if there is no dilution of the urine in response to water load, then this patient is a case of syndrome of inappropriate ADH secretion. So the treatment of the hyponatremia must be individualized, considering the etiology, rate of development, whether it is acute case or chronic, severity, and the clinical signs and symptoms. The dictum is the hyponatremia which develops quickly should be treated fast, whereas the hyponatremia which develops slowly should be corrected slowly. The goal of therapy is to raise the plasma sodium concentration at the safe rate, to replace the sodium deficit or potassium deficit, or both, to correct the underlying etiology. In general, the hyponatremia is corrected acutely by giving sodium to the patient who are volume depleted, and the patients who are normovolemic or edematous, and there we have to uh, do the fluid restriction. Patients with the chronic hyponatremia, they are at increased risk of ODS, that is osmotic demyelination syndrome, if the plasma concentration, sodium concentration is incorrected more than 8 to 10 millimole per within first 24 hours, or more than 18 millimole within first 48 hours. So we have to be very careful while correcting the sodium. Response to interventions such as hypertonic saline, isotonic saline, or AVP antagonist may be highly unpredictable, such that the frequent monitoring of the plasma sodium concentration during the corrective therapy is imperative. So, the patients of the hyponatremia, if we have ruled out that the cause is hypovolemia, just salt and water supplementation is okay. If the patient is edematous or in a state of hypervolemia, then he should not be given salt. There should be water restriction, or we can give diuretics. And the patients of normovolemic hyponatremia, water restriction will work. Specific treatment: removal of the drug responsible for hyponatremia like diuretic, chlorpropamide, IV cyclophosphamide. If the patient has a post-operative pain or physical stress, we have to manage that also. The patients who have adrenal insufficiency, hypothyroidism, nephrotic syndrome, congestive heart failure, DKA or salt losing nephropathy, we have to treat the underlying cause. The choice of the IV fluid is 0.9% sodium chloride and 3% sodium chloride. These two are routinely used, and they have higher sodium concentration. They are used to treat hyponatremia. The patients who are case of SIADH, the infusion of 0.9% sodium chloride is not appropriate. When the hyponatremia is associated with hypovolemia or in the absence of fluid retention or edema, 0.9% saline is preferred fluid. But when the patient needs salt supplementation along with fluid restriction, then the hypertonic solution is preferred. For example, severe form of SIADH. These are the sodium concentration and the osmolality of the fluids which we should know. What is the sodium concentration and the osmolality of the various fluids? So coming to the hypovolemic hyponatremia, So these all hyponatremias are true hyponatremia. So the patients of the hypovolemic hyponatremia will be dehydrated if his urine sodium is less than 20 millimoles. It means kidneys are normal. So the cause here will be vomiting or diarrhea. If it is more than 20 millimole per liter, the cause may be diuretics use, primary adrenal insufficiency. So these patients will require both fluid and salt. So we will give IV isotonic saline like 0.9% sodium chloride or ORS containing fluid. We don't have to give 5% dextrose or 0.45% sodium chloride or isolate M unless the plasma sodium is corrected or it comes within normal range. If we give 5% dextrose or 0.45% sodium chloride or isolate M in patients of hypovolemic hyponatremia, it will further aggravate the hyponatremia. So we have to be very sure. Now, if the patient comes with hyponatremia, in a case of hypovolemic hyponatremia, how the sodium is given? So we have two methods. First, the conventional method, and second is the newer method. In conventional method, the amount of sodium which is required in 24 hours is calculated as total body water multiplied by desired sodium concentration minus the initial sodium concentration. But this method calculates the amount of sodium required to raise the sodium. After we calculate the requirement of sodium, it is confusing to select the sodium containing fluid and determine its infusion rate. And therefore the new method was invented. This method directly calculates the change in serum sodium concentration for a given infusate. We have to select the type and volume of the sodium containing fluid and calculate the expected change in sodium. For given target of change in sodium concentration, this formula can directly calculate the volume of the selected sodium containing fluid. So in this method, change in serum sodium concentration is equal to infusate sodium per liter minus serum sodium which is at present patient presents with, divided by total body weight, total body water in liter plus 1, or we can say infusate sodium plus potassium divided by infusate sodium per potassium per liter minus serum sodium divided by total body water in liter per 1 plus 1. But I usually use this conventional method of calculation of the sodium. So whatever method we use, we should not use or we should not correct sodium beyond 8 millimole in 24 hours from the initial sodium concentration. Okay, if for example, just take the example of a patient, if 70 kg male presents with hypovolemic hyponatremia with serum sodium of 110 millimole per liter, then the desired sodium concentration in this case will be 110 plus 8. I said we will not increase beyond 8. So desired concentration is 180 millimole per liter. The body water in male is 0.6 into body weight, and body weight in female is body water in 0.5 into. So the sodium requirement will be 0.6 into weight total body water. Total body water is here, he is 70 kg. 70 kg multiplied by 0.6. 70 multiplied by 0.6. Desired sodium is 118 minus 110. 110 is the patient presented with. So it will come to be 42 into 8, that is 336 millimole per liter. Coming to the management of the hypervolemic hyponatremia, as we know that in hypervolemic hyponatremia, the patient will be edematous, or we can say that he will have features of edema, that is peripheral edema. He may have clefts in the lungs or may have features of ascites. We will check urinary sodium. If it is less than 20 millimole per liter, it means his kidneys are fine, absorption of sodium is good. So the causes here will be cirrhosis or heart failure. And if urinary excretion is more than 20 millimole per liter, so it means patient is a case of renal failure. So in hypervolemic hyponatremia, our main target will be water restriction. So in mild cases, the water restriction is good. The water restriction is usually done on the basis of sum of urine output plus insensible water losses. Insensible water losses are the water loss in the respiratory system, by the GIT tract, in the through sweating, through the respiration. It is approximately 10 ml per kg body weight. For example, if 60 kg person with the urine output of 1 liter, his intake should be less than 1 liter plus 600 ml. 600 ml is the insensible level. So we should, it comes about 1600 ml. So we will give him water to drink, and it should be less than 1.5 liter. In most of the mild cases, the restricted water intake method works. However, the patients with moderate to severe cases, we have to give diuretic like furosemide 20 to 40 milligram per day. And in severe cases or refractory cases where the furosemide or diuretic don't work, or in the patients who have serum sodium of 105 or 110, then we will have to start the tolvaptan. Tolvaptan, it causes free water loss, and the criteria for starting the tolvaptan is when the serum sodium values are approximately 125 millimole per liter, or the patients who are refractory to diuretics or furosemide. It is given as a dose of 15 milligram per day. Then we can increase gradually its dose to 30 milligram per day, and it has to be given for 1 month only, because it causes liver dysfunction. So we should not give it beyond 30 days. Whenever we give tolvaptan to a patient of hypervolemic hyponatremia, as we know that it causes free water loss, so we can slightly increase the intake of water in such patients. Also remember, never give hypertonic saline in patients with hypervolemic hyponatremia. And also don't give tolvaptan in hypovolemic hyponatremia, because it causes water loss, and hypovolemic hyponatremic patients are usually dehydrated or they have low hydration status. In cases of euvolemic hyponatremia, as we know that the important causes are hypothyroidism, secondary adrenal insufficiency, and SIADH. We have to just treat the cause. In hypothyroidism, we know that there is decrease in the cardiac output, there is decreased GFR, and slight water retention in the body, which dilutes the sodium, but clinically there will be no edema. So in patients of euvolemic hyponatremia, always rule out the hypothyroidism. Similarly, in patients of secondary adrenal insufficiency usually occurs at the level of pituitary. There is glucocorticoid deficiency. As we know that glucocorticoids inhibit the ADH. If the glucocorticoids are deficient, then ADH will not be inhibited, so it will absorb water from the kidney and will cause dilutional hyponatremia. And similarly, the syndrome of inappropriate ADH secretion occurs in excess, and the causes of SIADH are CNS infection, pneumonia, drugs, post-operative pain. So excess of ADH in SIADH will cause more water reabsorption from the kidney, and because of volume expansion, the atria will be more stretched, more release of ANP, or we can say atrial natriuretic peptide. It will lead to natriuresis, This natriuresis usually prevents the clinical edema in these patients. So, in euvolemic hyponatremic patients, we have to treat the cause. For example, for hypothyroidism, give thyroxine. For SIADH, mild asymptomatic patients, water restriction is advised. And but water restriction here depends upon the ratio of the urinary sodium and urinary potassium divided by plasma sodium. If the ratio is 1, it means that more sodium and potassium are going in the urine, and this means there is less water excretion. And so if the ratio is more than 1, then water restriction should be less than 500, means we should give him water to drink only less than 500 ml per day. If the ratio is equal to 1, then the water can be given up to 500 to 700 ml per day, and if it is ratio is less than 1, then water restriction is 700 to 1000 ml per day. So whenever a patient of acute hyponatremia or acute severe symptomatic hyponatremia comes to us, always give 3% saline. It is because we don't want to overload the patient. So our aim should be that more maximum sodium should go inside. So in a patient of acute hyponatremia, our initial target should be increase the serum sodium by 4 millimole per liter in first 4 hours. It will take care of the CNS symptoms. Then we have to check the sodium every 2 to 4 hours. After this, treatment will be that of chronic hyponatremia. So in chronic hyponatremia, the rate of correction should be less than 8 millimole per liter in first 24 hours. Let us take example. If the patient comes with acute symptoms with serum sodium of 100 ml, 110 millimole per liter, we will correct it to 114 in first 4 hours. Then in the next 24 hours, we will correct it to 122 millimole per liter. That is 114 plus 8. That comes to be 122 millimole per liter. If the patient comes to emergency room with features of chronic hyponatremia of more than 48 hours with serum sodium of 110 millimole per liter, then we will correct it to plus 8 millimole per liter. That is 118 millimole per liter in 24 hours. And then thereafter we can increase it by 6 to 8 millimole per every 24 hours. Rapid sodium correction should never be done because rapid sodium correction causes pontine osmotic myelinosis, which can present as a quadriplegia or locked in state, and we call it as a osmotic demyelination syndrome. So the osmotic demyelination syndrome is because of rapid correction of the sodium. What happens here? Whenever we correct the sodium slowly, we should always correct the sodium slowly. Otherwise, if we correct the sodium very rapidly, the patient may develop the central pontine myelinosis or CPM, or we call it as osmotic demyelination syndrome. The patient may have dysarthria, dysphagia, flaccid quadriplegia, pseudobulbar palsy, and coma. What happens here? There occurs rapid demyelination without inflammation in the base of the bones, with the relative sparing of the axons and the nerve cells. When we should stop the saline? Stop the saline if these three things are achieved. First, the symptoms of the patient resolves. Serum sodium level of 125 millimole per liter is achieved. Always try to keep patient hyponatremic, never overcorrect or never correct to his normal range. Or once we have increased the sodium concentration of plus 20 millimole from the initial concentration, we have total increase in plus 20 millimole. So when these three criteria are met, any of the three criteria is met, we can stop the infusion. Let us take few cases. For example, a 45-year-old male present with severe vomiting with loose motion, Clinically, he is lethargic, dehydrated, pulse is 110 per minute, BP 96 by 60, his weight is 75 kg. He doesn't have any seizure, no coma. So the patient is lethargic and dehydrated only. His serum sodium is 115. So it is a case of hypovolemic hyponatremia. We assume he has this hyponatremia more than 24 hours. So the maximum correction should be 8 millimole per hour. Always remember, never overcorrect beyond 8 millimole per hour. Sorry, 8 millimole in 24 hours. We have to give water along with sodium as the patient has water loss. How do we calculate the amount of sodium required? Body water into desired sodium concentration minus initial concentration. For men, we multiply the weight with the zero point 0.6. Desired sodium concentration here will be, he has 115. We will add 8, it is 123. 123 minus 115, it comes to be 45 into 8, 360 millimoles of sodium is to be given in 24 hours. So, as we know, normal saline 0.9% sodium chloride contains 154 ml millimole of sodium in 1 liter of saline. So 360 millimole will be present in 2.33 liter of normal saline. So we will have to give 2.33 liter of normal saline in 24 hours. Another case, a 65-year-old post-operative male patient who underwent total knee replacement, right-sided. He was given 5% dextrose 3 liter with liberal oral fluids. Next day, patient become confused, irrelevant, talks and develop seizure within 24 hours. So it is a case of acute severe hyponatremia. He doesn't have any signs of dehydration, edema, cramps in the lungs. BP is 130 by 80, pulse is 86 per minute, serum sodium is 112, weight is 70 kg. So the diagnosis here is acute severe symptomatic euvolemic hyponatremia. ADH increase is due to postoperative pain. ADH also has increased water absorption and the patient is given oral liberal fluid. So here we will increase the sodium concentration by +4 in initial 4 hours, then in next 24 hours we can increase it to +8. So sodium given here is to be given as body water into desired sodium concentration minus initial sodium concentration. So the body water 0.6 into his weight divided by sodium concentration is 112. We have to increase it just by 4. 116 minus 112 is equal to 42 into 4, that comes out to 168 millimole in first 4 hours. So it comes to be 513 millimole. 513 millimole is present in 1 liter. That is 3% sodium chloride contains 1 liter of 3% sodium chloride contains 513 millimole. So 168 millimole will be present in 327.4 millimole of saline. It has to be given in the 4 hours. So the infusion rate will be 82 ml per hour. And after 4 hours, we will increase the sodium by +8 or depending upon the symptoms in the next 24 hours. And we will use a similar formula for the upcoming 24 hours or other days also. Coming to the third case, a 62-year-old female, she reported with for routine checkup with, she is a known case of heart failure with type 2 diabetes. She is on ACE inhibitors, carvedilol, spironolactone, dapagliflozin. Clinically, hydration is fair. She has a pitting pedal edema, BP 126/84, weight is 70 kg, higher motor function are normal, serum sodium is 120 millimole per liter. Also, it is, since edema is present, hypervolemic hyponatremia case is there. Her higher motor functionals are normal. She is asymptomatic patient. We will just treat the underlying cause. So here we can give water restriction and furosemide as the pitting edema is present. Wait and watch for the response. If this is refractory and sodium remains less than 125 millimole per liter, that we can try tolvaptan. So the take home message is, Whenever the patient of hyponatremia comes to us, we have to rule out first whether it is a true or uh, pseudo hyponatremia. True hyponatremia will always have a low plasma osmolality. Then we have to see whether it is a symptomatic hyponatremia. If patient is euvolemic hyponatremia, we have to give hypertonic saline infusion. If patient has a hypovolemia, then normal saline can be given. If patient has a hypervolemic, then we have to give water restriction mainly, or we can add tolvaptan or furosemide depending upon the case. Always avoid hyper or normonatremia during the initial 5 days, means we have not to correct or overcorrect the hyponatremia. Just try to keep the patient hyponatremic initial 5 days, and the patients who are asymptomatic, or the hyponatremic patient who present as asymptomatic, we have to treat the underlying disorder. So this is the final chart about the approach to a patient with hyponatremia, or we can say true hyponatremia. I have taken the guidance from Harrison's Principles of Internal Medicine 20th edition, Washington Manual of Medical Therapeutics, and Fluid Therapy by Dr. Sanjay Pandey. Thank you very much.